Welcome to our lecture course, and today we'll talk with you about the basic symptoms and syndromes of the patient with blood diseases. First of all, I want to remember you that our blood is formed from plasma, liquid part, which must be nearly 50-60%, and the blood elements, which count is 40-45%. Main blood elements are erythrocyte, leukocyte, and platelets. Leukocytes divided on some group which have specific functions, and first of all they divided on agranulocytes and granulocytes depending structure of the cells. Granulocytes divided on basophils, eosinophils, and neutrophils. Agranulocytes divided on lymphocytes and monocytes. If we are talking about blood diseases, approximately they may be divided on three groups depending activity of main blood elements. Anemia, which appears due to affection activity of red blood cells. Hemoblastosis, primary appears due to affection of white blood cells, and hemorrhagic diathesis, which tightly correlated with activity of platelets. We'll stop on every blood diseases separately and give the characteristics. Anemia is more often pathology of blood system. It appears due to loss of blood. It may be a result of disordered hematopoiesis and excessive hemolysis when the destructive process exceeds process of formation red blood cells. If we are talking about anemia due to loss of blood, first of all, it is acute or chronic post-hemorrhagic anemia. It's more often met in our clinical practice. Anemia due to disordered hematopoiesis, divided on two main types: iron deficiency, when production of hemoglobin restricted, and vitamin B12 deficiency, when normal erythropoiesis, other words, maturation of red blood cells, disturbed. And hematopoiesis tightly correlated with activity of bone marrow, inhibition of bone marrow due to exogenous or endogenous intoxication, due to action of radiation or replacement of the red bone marrow by myeloma or multiply metastasis, also manifested with anemia. And blood group anemia due to excessive hemolysis, such as named hemolytic anemia, which appears due to intensive destruction of red blood cells. But in clinical practice, we'll often meet with mixed anemia, iron deficiency combined with B12 deficiency, B12 deficiency combined with hemolytic, and any other combination. Anemia classified depending characteristic of saturation of red blood cells with hemoglobin, and we distinguished nomochromic, hypochromic, and hyperchromic anemia depending of color index, which normally varies from 0.85 to 1.15, and if it's decreased or increased, we are talking about hypo or hyperchromic anemia. Nomochromic anemia. First of all, there are hemolytic anemia because process saturation of erythrocytes with hemoglobin not change. Process hematopoiesis also near the norm. It appears due to excessive destruction of red blood cells. Hypoplastic anemia also may be normochromic, such as aplastic anemia, which appear due to decreased activity of bone marrow. Acute posthemorrhagic anemia may be normochromic, and secondary anemia, which appears due to primary chronic long-standing diseases which later involve in pathological process hematopoiesis. If we are talking about hypochromic anemia, which is iron deficiency anemia, because iron is main structural element of hemoglobin. And hyperchromic anemia, which is B12 and folic deficiency or Addison-Birmer anemia. Anemia may be classified depending activity of bone marrow, which determine dependent count of reticulocytes, which normally varies from 2 to 10 per mile. And if we are talking about anemia dependent of activity bone marrow, we distinguished regenerative, hyperregenerative, and aregenerative anemia. And will control sometimes dosage of medicine depending activity of bone marrow. Let's talk on characteristic iron deficiency anemia. Anemia of which is conditioned by the iron deficiency in the blood, bone marrow, and depot. When we are talking about iron deficiency state, we distinguish two periods: latent, masked, and manifested iron deficiency anemia. Latent masked iron deficiency state is characterized with normal count hemoglobin and erythrocytes in blood, but level of iron in the depot and transport iron in the blood decreased. When the anemia pronounced, all metabolic funds of iron decreased, and we can reveal signs of anemia in peripheral blood due to decreased count of hemoglobin and erythrocytes. From physiology, you know that iron takes active part in metabolic process in our organism because it controls some metabolic regulation function, transport of oxygen, tissue respiration, and immunological resistance. Iron presented in our organism in two forms, heme and non-heme iron. Heme iron, first of all, presented in content of hemoglobin, myoglobin, some cytochromes and enzymes. Non-heme iron, first of all, presented in deposited form, such as ferritin, hemosiderin, transferrin, and some enzymes. Iron presented in our organism nearest 4.5 to 5 gram. And if you see on this scheme, you see that more than 50% of iron used for hematopoiesis, such name erythron iron, and only other parts deposited take part in transport enzymes and tissue breathing. Iron presented in our enters in our organism with food, and first of all with animal food. More active iron presented in meat. and it is more optimal for our organism because it is presented in form uh, to degree iron, which more easy assimilable and used of our organism. In other food, first of all, in some fruits and vegetables, iron presented in form third degree, of which obligatory must be transformed in iron second degree depending activity of hydrochloric acid into the stomach, and you'll understand this process tightly correlated with activity of stomach, and patient with hypoacidic function of stomach cannot actively and optimally use iron from the food where it is presented in iron third degree. After absorption, iron actively used with our organism. But we must remember that absorption of iron intensifies ascorbic acid, fructose, sorbate, alcohol, orange juice, and animal protein. And if we'll correct patient with iron deficiency anemia, will give him some dietary recommendation. And we must remember that absorption of iron inhibited by thiotenins, antacid, enterosorbate, milk, vegetable fibers, and fat. And when you will prescribe iron medicines, will recommend to the patient some dietary recommendation. Let's very fast remember iron metabolism. After absorption, iron enters in blood plasma with transport iron transferrin, which transports the iron first of all in bone marrow for erythropoiesis, and we can control its activity with red blood cell due to blood analysis. Other parts of iron will be deposited in liver and spleen in form of ferritin and hemosiderin, which as needed very easy come back in blood plasma and with transferrin transport in bone marrow for hematopoiesis. Some parts of iron go to the tissue, which is functional iron in form of myoglobin, same cytochromes, and enzymes which take active part in metabolic process. But if needed, it's again come back in blood plasma and first of all with transferrin transported in bone marrow because primary iron must be in definite condition in bone marrow to control hematopoiesis. Erythrocytes destroyed into the spleen and iron utilized, but it's not removed from our organism. It's again come back in blood plasma and with transferrin again transported in bone marrow. You see, our organism effectively control metabolism of iron and hold as possible our organism from its deficiency, because our organism doesn't lose iron. All iron elements completely used for one or other metabolic process, but first of all for hematopoiesis. Every day we'll take the food from which 15-20 grams of iron enters in our organism. But for normal metabolism and control of iron in our organism, only 1 to 1.5 milligram per day is enough. But for hematopoiesis, use 25 milligram iron per day, but not only iron which enters in our organism. You saw from preceding slide, iron completely used during metabolism into our organism, and only some amount of iron is enough to control its level in our organism. Physiologically, every day we lose nearly 1 milligram of iron with pieces with superficial epithelium. And let's see, if we lose 1 milliliter of blood, which is some drop of blood, we lose 0.5 milligram of iron. If we lose nearly 2 teaspoons of blood every day, which is approximately 10 milliliters, we lose 5 milligram of iron. And if this process prolonged, will be this correlation between loss and entering of iron in our organism, and after some period, first of all, will be deficiency of iron in depot. We are talking about mask or latent period of anemia, which then may be transformed in pronounced clinical manifestation anemia. First of all, due to hemorrhoids, bleeding on which patient not intensively lost attention and go to the doctor in time, and some other bleeding about which we'll say later. Etiology of iron deficiency anemia is chronic hemorrhage, first of all. And when the patient enters in hospital with iron deficiency anemia, first of all, we'll start our diagnosis way from excluding any chronic source of bleeding. And first of all, we'll start from gastrointestinal tract, because more often source of bleeding is gastric or duodenal ulcer, canceromatous process in gastrointestinal tract, hemorrhoids about which I said you. If gastrointestinal tract not involved, then we'll examine patient of some helminthes. It is more difficult way, but we must remember that helminthes is provoked factors of iron deficiency anemia. Next step is examination of kidney and lung, which disease is also accompanied with iron deficiency anemia, and in women will obligatory examine gynecological status. Other cause of iron deficiency anemia is decreased iron absorption. First of all, there are a group of patients with after resection of stomach, in which appears a gastric anemia. We must remember about some intestinal diseases, and first of all, diseases of small intestine, because this part of gastrointestinal tract control process of absorption. We'll obligatory ask the patient about his diet, because deficiency of iron in food also is source of iron deficiency anemia. We must remember about some period when the need of iron increased, and first of all, it is a younger period, and we must remember about juvenile sclerosis, iron deficiency anemia, which appears in a younger woman when the menstrual cycle started early, 11, 12 years, when the a woman organism not prepared to constant loss of blood, especially if the time and amount of menstrual blood significant. We must remember about pregnancy, labor, leukaemia period, when the loss of iron divided on two organisms, mothers and fetal and then newborn organism, and dietary recommendation must be pay more attention. We must remember about sportsmen, but intensive sport training needed more active using of iron, and first of all in form of myoglobin. And rare case cause of iron deficiency anemia may be infrequent iron transport, which may be revealed with special examination. Provoke etiological factors, first of all, provoke latent iron deficiency, and first of all will be deficient of tissue and transport iron. Later will be decreased synthesis of heme and decreased activity iron containing and iron dependent tissue enzymes. As a result, will be decreased formation of hemoglobin, and we can reveal hypochromic anemia in blood analysis. As a result, it's accompanied with tissue hypoxia and some degenerative process, especially in tissue which very sensitive to oxygen level. Hypochromic anemia is provoked factor myocardial dystrophy, because you know that heart is more active muscle in our organism and it is needed definite level of oxygen for normal metabolism and nutrition. Decreased synthesis of heme accompanied with decreased synthesis of myoglobin, because it is a form of heme iron. As a result, myocardial dystrophy pronounced and progresses. Patient feels problem with peripheral muscles due to its atrophy and weakness, which progresses due to decreased activity iron containing enzymes and tissue breathing. Deficiency of decreased activity of non-heme iron will be problem with epithelium of tissue, which clinically manifested with atrophy of gastrointestinal tract and problem with skin and its appendages due to trophic disturbances. Secondary decreased activity of iron containing tissue enzymes accompanied with decreased protective function of leukocytes. If you remember, some times ago we said about action of the iron in immune response. And all this process finish with tissue hypoxia and the degeneration and some dystrophic process. It is pathogenic mechanism of the iron deficiency anemia. Clinical picture: iron deficiency anemia may be divided on two main syndromes, anemic and siderapenic. I'll pay your attention. Anemic and siderapenic syndrome, about which you forgot on exam. Let's stop on manifestation of anemic syndrome, which is formed due to decreased hemoglobin and erythrocyte content and as a result tissue hypoxia. Patient complains of weakness, increased fatigue, decreased work capacity. For compensation, actively involved respiratory and cardiovascular system. Patient feels dyspnea and palpitation, first of all after active physical exercise, then physical activity decreases, but dyspnea and palpitation becomes more pronounced. Patient complains of dizziness, darkness in eyes, feeling of noise in the ears, sometimes fainting. If the patient activity connected with scientific work, he pay attention on decreased intellectual work capacity, decreased memory, and sleepiness as a result of brain hypoxia. On inspection, we'll pay attention first of all on skin color and mucus if you compare normal and anemic mucus of eyelid. Skin of the patient will be pale, sometimes with light green color, chlorosis, sometimes maybe pastels of chin, feet, and face, but will obligatory pay attention on activity cardiovascular system, which manifested with tachycardia for compensation of hypoxia due to progressive myocardial dystrophy. Heart sound becomes dull due to decrease its muscular component. Later we can hear systolic murmur over all heart points due to decreased uh, properties of blood. It becomes liquid and easy go with turbulent movements, which will be heard as murmur. Over the jugular vein, we can hear nuns murmur, but it is possible in heavy anemia when the level of red blood cells significantly decrease. And blood pressure predilected to hypertension due to decreased activity of cardiovascular system and decreased heart stroke because progressive cardiomyopathy. Siderapenic syndrome appears due to tissue iron deficiency and decreased activity of some enzymes. Clinical picture is characterized with pivoted test sclerotica. Patient aridity is chalk, clay, coal, phosphate, root dull. Patient feels predilecting to spicy and solenous food. Will pay attention on his pivoted affection. Patient feels predilection to the unpleasant smells, kerosene, benzene, acetone, paint, naphthalene. Sometimes it is characteristic for pregnant women, also due to deficiency of iron. Later, patients feel expressed muscular weakness and fatigue. We remember pathogenic process and decreased tissue activity due to hypoxia and deficiency of myoglobin and enzyme activity. Then patient may pay attention on dystrophic changes of the skin and its appendages. First of all, it is characteristic for women because skin becomes dry, sometimes slightly scaling. Hair is brittle, early gray and showing the tendency to falling. Nails becomes flat, brittle, opaque, marked by transverse folds, sometimes spoon-like. We are talking about chylomicria symptoms. And next slide demonstrates you easy falling of hair, dry, wrinkled skin, and specific changing of nails with transverse folds and formation of spoon-like nails with easy cold drops of water. Chylomicria symptom. Patient feels problem with gastrointestinal tract and first of all will examine oral cavity to reveal angular stomatitis, which characterized with formation fissures in the mouth angle. We are talking about atrophic glossitis because sensation of the arching pain in the tongue area, reddish lips, then the papilla of the tongue are leveled due to the atrophy and tongue becomes smooth. Severe problem with teeth because the easy destroyed formation of caries, and involvement of gums predilected to purulent inflammation. We are talking about such name alveolar pyorrhea. From the mouth of the patient may be specific, or the UC formation fissures in mouth angle, you see progressive caries, and you see smooth tongue with atrophic pupillus. Gastrointestinal tract mucus involved in pathological process, and due to the atrophy will be dryness of esophageal mucosa. As a result, patient feels problem with swallowing of food, dysphagia, which appears due to dryness of esophagus mucus. We are talking about siderapenic dysphagia, on contrary from true dysphagia due to narrowing of esophagus lumen. Atrophic process develops into the stomach and intestine mucus with formation of atrophic gastritis and enteritis. Patient feels symptoms of dyspepsia and problem with defecation. Sometimes may be revealed symptoms of blue sclera due to thinning of the sclera because infrequent collagen synthesis, and we'll see subline vessels. In heavy long-standing anemia, patient can feel problem with urination, imperative desire of urination. As a result, patient cannot go out from home and feels some problem with his life activity. And sometimes patient predilected to subfebrile fever. We are talking about siderapenic subfebrile condition because no symptoms of inflammatory or toxic process. Diagnosis is based on examination of blood. In period of latent iron deficiency, first of all, we'll examine serum iron, total plasma iron binding capacity, and percentage transferring saturation with iron, which may be determined by formula, and level of ferritin. All these indices decrease except total plasma iron binding capacity, which increased to compensate iron deficiency. Main indices which help reveal your latent iron deficiency, each is determination serum iron, total plasma iron binding capacity, and ferritin. Iron deficiency anemia will be revealed due to routine blood examination when we reveal decreased content of hemoglobin and red blood cells, color index becomes less than 0.85, erythrocytes becomes pale, we are talking about hyperchromia, it's small microcytosis and with different pathological shape, poikilocytosis. Level of reticulocytes near its norm and maybe increased erythrocyte sedimentation rate because blood liquid and erythrocyte easy sedimentated due to heavy load. If you see on this slide, you see different shape of erythrocyte, poikilocytosis, and decrease its diameter, microcytosis. Upper slide is characteristic for normal size of erythrocyte and erythrocyte in iron deficiency anemia. Microscopic blood examination. Compare again normal blood and iron deficiency anemia, pale and small erythrocytes with different shape. B12 folic deficiency, Addison-Birmer anemia. It may be separate only B12 or isolated folic deficiency anemia, but when we'll stop on pathogenesis formation of B12 deficiency anemia, you will understand why in clinical practice more often we'll meet with combined B12 folic deficiency anemia. Vitamin B12 take part in maturation of erythrocyte, and it enters in our organism only with animals' food. Then into the stomach, due to proteolytic enzymes and hydrochloric acid, will be or will extrinsic factors from vitamin B12, which into the duodenum combined with gastromucoprotein, such name intrinsic factors, which is produced by parietal cells of the stomach fundus. If you see on this scheme, you understand metabolism of vitamin B12 tightly correlated with activity of the stomach enzymes and hydrochloric acid. After that, vitamin B12 may be absorbed into the ileum and enters into the blood, from which it goes in bone marrow for control of process red blood cell maturation. Other part deposited into the liver. Vitamin B12 except hemopoietic activity needed for activity of nervous system, because in our organism it's presented in two forms. Methylcobalamin, which needed for normal synthesis of desoxyribonucleic acid, which take part in hematopoiesis, maturation of red blood cells, and control structure of gastrointestinal tract epithelium. Other form of vitamin B12, desoxyadenosylcobalamin, take part in normal metabolism myelin of the nerve fibers and control activity of peripheral nervous system. Two forms of vitamin B12 presented in our organism. Let's stop on metabolism folic acid. Folic acid enters in our organism with any fruits and vegetable, and also presented in animals' food. As a result, our organism doesn't feel deficiency of folic acid only during long starvation. But folic acid deposited in inactive state into the liver and may be activated only due to activity of methylcobalamin, and only active folic acid take part in normal synthesis desoxyribonucleic acid, which take part in normal hematopoiesis. You see correlation between activity of vitamin B12 and folic acid, and you can understand why in clinical practice rare case will use separate folic and B12 deficiency anemia. Etiological factors formation of B12 deficiency anemia. First of all, there are problems with stomach, because you saw assimilation of vitamin B12 is possible only due to normal activity of the stomach. Other words, there are all group of patients with atrophic gastritis. Patient with total resection of stomach needed artificial injection of vitamin B12 on next all his life. And sometimes congenital infrequent secretion of gastro-mucoprotein, which restrict normal assimilation of vitamin B12. And we remember about new growths and toxic action of alcohol on the stomach mucus, which is provoke factors of atrophic gastritis. Other problem with small intestine, because final absorption of B12 appears in small intestine, and resection more than 50 centimeters of ileum may be heavy for the patient and provoke fractures of vitamin B12 deficiency anemia. We must remember about some specific diseases of small intestine, such as Crohn's diseases, amyloidosis, because problem with small intestine clinically manifested with malabsorption syndrome. Competitive expenditure of the vitamin B12, and first of all due to invasion by helminths, Botryocephalus, and formation of diverticulum in small intestine. We must remember about increased change of vitamin B12 in pregnant women, especially polycarpous pregnancy. Patients with chronic hemolytic anemia and myeloproliferative diseases predilected to secondary B12 deficiency anemia and pathology of thyroid gland thyrotoxicosis accompanied with secondary B12 deficiency anemia. Dietary factors. We remember that vitamin B12 first of all presented in animal food, and strong vegetable patient predilected to formation B12 deficiency anemia. And rare case infrequent transport of the vitamin B12 due to problem with some enzymes which must be established only in specific institutions. Pathogenesis of B12 deficiency anemia. Due to activation of provoked etiological factors and formation deficiency of vitamin B12, our organism feel deficiency of methyl and desoxyadenosylcobalamin. Deficiency methylcobalamin manifested with atrophic gastrointestinal tract mucus, which progresses decreased absorption of vitamin B12, which manifested with atrophic glossitis, gastritis, and enteritis. As a result, decreased absorption of vitamin B12, disordered erythropoiesis, granulopoiesis, thrombocytopiesis, other words, will be pancytopenia, because into the blood we can reveal decreased all main blood cells, red blood cells, white blood cells, and plaquenil. Deficiency desoxyadenosylcobalamin manifested with disordered fatty acid metabolism. As a result, formation of toxic methylmalonic and propionic acid accumulation, which are toxic for nervous system, and clinically formation specific neurological symptoms, which will be named as funicular myellosis. As a result, clinical picture patient with B12 deficiency anemia will be characterized with three groups of syndrome: hemopoietic, digestive, and nervous. Three clinical syndrome manifestation: hemopoietic, digestive, and nervous. Hemopoietic system affection characterized with anemic syndrome, on which will stop, and it completely resembles iron deficiency anemia. because it appeared due to hypoxia. But on contrary from iron deficiency anemia, B12 deficiency anemia often accompanied with subfebrile temperature due to hemolysis, because if you remember normal physiology, you must know that disturbed maturation of erythrocytes accompanied with changing its size. Erythrocytes will be predilected to macrocytosis, megalocytosis, and sometimes size erythrocyte not correlated with diameter of capillaries network, which provoke its early destruction and as a result formation secondary hemolytic anemia. On inspection, we'll pay attention on color of the skin, and mucus and skin will be pale with some yellowish tint due to secondary hemolytic anemia and hemolytic jaundice. When we'll tap over the flat bone, patient can feel discomfort, sometimes pain due to activity of bone marrow, hyperplasia of bone marrow. Nervous system affection, neurological syndrome, manifested with weakness of the legs and as a result affection of gait. Then patient feels some paresthesia and spastic paresis or paralysis of lower extremities. Decreased tenderness reflexes, and as a result, patient feels problems with walking, sometimes needed stretch wheelchair or stretch car. Affected function of urinary bladder and rectum manifested with incontinence, urination, and defecation. Later, we can reveal symptom disordered activity, central nervous system. Primary, it's manifested with deranged sleep and emotional lability. Later, with some mental disorders and disordered behavior of the patient, predilection to psychosis, delirium, depression, hallucination, other word, non-control psychic of the patient. All these problems appears due to decreased formation of desoxymethylcobalamin and formation funicular myelinosis. Digestive system affection appears due to atrophy of the gastrointestinal tract mucus. As a result, patient feels discomfort after eating, and as a result, loses appetite due to formation dyspeptic symptom and due to brain hypoxia and depression of the appetite center. Patient feels pain and burning sensation in the tongue and lip due to formation atrophic glossitis, which more pronounced than patient with iron deficiency anemia. Patient feels regurgitation and irritation and discomfort after eating, accompanied with diarrhea, sometimes constipation, because atrophic process into the stomach and intestine. We are talking about atrophic gastritis and colitis. On inspection, we'll pay attention on examination of oral cavity, and we see that mouth mucosa and throat predilected to atrophic process. Tongue becomes smooth, bright red due to pronounced atrophy of papilla. We are talking about Hunter glossitis. Atrophic process into the oral cavity is called Hunter's glossitis. Patient feels tendency to caries, but not such significant as with iron deficiency anemia. On palpation, we can reveal hepatorenal syndrome, enlargement liver and spleen due to hemolytic anemia and hemolytic jaundice. You see patient with formation atrophic glossitis, bright red tongue with atrophic papilla, predilection to caries, but not such significant as for iron deficiency anemia. Diagnosis is based on examination of blood, but we obligatory check level of vitamin B12 and send blood of the patient on biochemical examination, liver test, and examine digestive and nervous system with specific tests. Blood analysis will reveal decreased erythrocyte content but increased hemoglobin saturation. As a result, color index is higher than 1.5, which is hyperchromic anemia. Erythrocytes macro predilected to macro or megalocytosis because not finished process maturation. As a result, we can see remnants of nucleus into the erythrocyte, such named jolly bodies and Cabot rings. And we remember that patients with B12 deficiency anemia predilected to secondary leuka and thrombocytopenia and increased ESA due to liquid blood. You can compare size of normal erythrocyte and erythrocyte patients with B12 deficiency anemia. And we can see remnants of the nucleus. Maturated erythrocytes are free from nucleus. Process of maturation disturbed. As a result, we will see jolly bodies and Cabot rings, remnants of the erythrocyte nucleus. Microscopic examination of the blood, you also reveal macrocytes, of which hyperchromic and with remnants of nucleus. And this slide demonstrates you difference between iron deficiency and B12 deficiency anemia. Pale microcyte, hyperchromic macrocytes with remnants of nucleus. Folic deficiency anemia. Rare case appears separately, but if we'll diagnose this folic deficiency anemia, on contrary from B12 deficiency anemia, it hasn't signs affection of nervous system and atrophic process of gastrointestinal tract, because folic acid take part only in hematopoiesis and manifested only with hyperchromic anemia. Hemolytic anemia. Hemolytic anemia, divided on two groups depending its origin, congenital and acquired, due to intracellular or intravascular hemolysis. Each is characterized with anemic syndrome, which has same signs as iron and B12 deficiency anemia because it's formed due to hypoxia, but hemolytic anemia is normochromic and accompanied with reticulocytosis as protective response on abnormal destruction of red blood cells. Other syndrome which is characteristic for hemolytic anemia is hemolytic jaundice. Patients with hemolytic anemia has specific lemon color of skin due to secondary hemolytic jaundice. Patient feels pain in right and left hypochondrium. Pay attention on dark urine and feces due to increased formation urobilin and steatobilin, about which we said some lectures ago when we studied liver syndrome. Next questions of our today's lecture: hemoblastosis. which is characterized with progressive cell hyperplasia in the hematopoietic organs, with pronounced prevalence of certain cells proliferation over their differentiation or maturation. Other word, blood overfilled with blood cells, but they not completely maturated. Other word, that they hadn't the normal functional activity. Other characteristic of hemoblastosis is substitution or metaplasia of the pathological cells for normal cells of all hematopoietic organs, and development pathological foci hematopoiesis in various organs. They are characteristic of hemoblastosis. Hemoblastosis divided on some groups. Depending origin of disturbed hematopoiesis, we distinguish two groups of hemoblastosis: leukemia, which start from bone marrow, and hematosarcoma or malignant lymphoma, which origin in other hematopoietic organs. Leukemia divided on two groups, acute and chronic, and I'll pay your attention if later we search with you that acute or chronic diseases depend from anamnesis. Hemoblastosis classification on acute and chronic depends from blood analysis and analysis of bone marrow, on which we'll stop later. We'll stop today on characteristic some chronic leukemia, which divided on two groups, lympho and myeloproliferative. Example of lymphoproliferative leukemia is lymphoid leukemia. Myeloproliferative leukemia, which is myeloleukemia and erythemia. We'll talk about hematosarcoma on example of lymphogranulomatosis. Leukemia is malignant tumors of the hematopoietic system with primary localization in bone marrow, and then spread on all other hematopoietic organs. Etiological factors of leukemia are not completely studied, but we know that more often it appears after action of ionized radiation, some chemical substances, and virus infection. And we must remember about genetic factors. I said we distinguish acute and chronic leukemia only depending analysis of blood and histological examination of bone marrow. And if hematopoiesis is transformed at the expense of low differentiated, such names blast cells, we are talking about acute leukemia, because hematopoiesis completely loses functional activity, and you'll understand prognosis of the patient is very, very bad because blood cells are unable to take its function. Chronic leukemia, hematopoiesis is transformed at the expense of more maturated cells, and some cells has functional differentiation. Other words, patient with chronic leukemia portionally loses functional activity of blood cells, and organism is able to live, and this process more easily compensated, and now we have some medicines which can stop pathological process and come back process of maturation nearly no. Onset of the disease may be different order. It may appear fastly and progressively. We are talking about acute onset. It may be manifested with expressed hemorrhagic phenomena. Some patients characterized with slow onset, latent development of disease. And sometimes diseases develops without intensive clinical manifestation and casually revealed due to routine blood examination. Acute development characterized with high fever, with remittent or hectic type, when the fever suddenly increases and significantly drops. It's accompanied with profuse sweating and chills. Pronounced weakness. Patient feels pain in the joint due to abnormal activization of hematopoiesis. Feels pain in abdomen due to enlarged lymph nodes, and painful swallowing because oftenly acute leukemia starts from the abnormal leukemic tonsillitis, which primarily may be assessed as usual purulent tonsillitis, but it has specific diagnosis features. If the leukemia manifested with hemorrhagic syndrome, patient enters in hospital with various localization profuse bleeding. It may be stomach bleeding, it may be uterus bleeding for women, it may be nasal bleeding which cannot stop in home contents, or any subcutaneous bruise without provoke fractures. Slow onset is characteristic for chronic leukemia. When the patient condition gradually changes, he feels progressive increased weakness, rapid fatigue, moderate muscular and joint pain, and sometimes a hemorrhage which difficulty stop in home condition. And latent onset, when the disease revealed due to examination of the patient with other disease, or patient go due to enlarged spleen or some groups of lymph nodes. Developed clinical picture characterized with next syndromes. I want that you remember and understand this principle, and then you can easily explain on exam complaints and visible signs of leukemia. First of all, hyperplastic syndrome. If you remember, we said when we gave characteristic of leukemia, which is abnormal non-controlled proliferation of hematopoietic organ. Then intoxication, because into the organism circulated abnormal elements, not maturated cells. Immunodeficient due to affection activity of white blood cells. Hemorrhagic due to decreased activity of platelets, and anemic due to decreased activity of red blood cells. If you remember these 5 syndromes, you very easy explain clinical picture of leukemia. Let's give characteristic of every syndrome. Hyperplastic, manifested with leukosis infiltration all organs and tissue. And first of all, will reveal increased peripheral lymph nodes, hepato and splenomegaly. I said you about necrotic tonsillitis, ulcerous tonsillitis with specific unpleasant odor. Patient predilected to inflammation of gums, gingivitis and stomatitis, and morbidity during tapping on the flat bones due to intensive hematopoiesis. More grave if the leukolysis infiltration go to central nervous system, brain and spinal cord, which manifested with meningitis, encephalitis, severe pain in spinal cord, We are talking about neuroleukaemia, and sometimes primary patient enters in neurological or emergency aid department, and only after blood analysis will clear primary and true diseases. Intoxication syndrome is formed due to circulation of abnormal cells and manifested with high fever, chills, profuse sweating, pronounced weakness, headache. Patient loses weight because cannot normally eat. A patient cannot walk due to muscular atrophy and feels nausea and vomiting due to progressive intoxication. Immunodeficiency syndrome manifested predilection of the patient with various inflammatory diseases, which predilected to purulent process, not usual bronchitis or pneumonia, purulent destructive process. And doctor must pay attention if the patient oftenly sick from any inflamed disease, obligatory needed controlled blood analysis. Why we said you blood analysis and urine analysis for every patient with enters in hospital or go to polyclinic. Hemorrhagic syndrome manifested with different bleeding, skin hemorrhage due to thrombocytopenia and decreased resistance of the vessels, and anemic syndrome characterized with common anemic syndrome about which we said you sometimes ago. On inspection, we'll pay attention on the progressive gravity of the patient condition, and it's more manifested in terminal period when the condition of patient becomes grave. We'll pay attention first of all of common behavior of the patient. Skin will be pale, sometimes with yellowish or grayish hue. It's moist, but its turgor decreased. We see traces of subcutaneous and intracutaneous hemorrhages. Or we can reveal early formation of necrosis and both bed sores due to decreased activity of the patient due to muscular atrophy, due to hypoxia, disturbed blood circulation. Patient predilected to ulcerous and necrotic tonsillitis, gingivitis, stomatitis. As a result, from the mouth will be specific unpleasant odor. When will exam tonsil, they covered with poorly removable gray or yellowish coat, which helps the doctor differentiate from usual inflamed tonsillitis. We can reveal increased peripheral lymph node, especially on the neck and supra and subclavicular and axillary region. Patient predilected to cachexia. You see patient with progressive leukemia. Different purulent foci, enlarged lymph nodes, and first of all neck lymph node. On palpation, we reveal enlarged separate groups of lymph nodes, spleen and liver, but main diagnostic way is blood analysis and examination of bone marrow due to sternal puncture. Let's stop on characteristic blood analysis patient with leukemia, which is main examination for differentiation between acute and chronic leukemia. In any case, will be increased or significantly decreased count of white blood cells, which accompanied with thrombocytopenia and anemia, secondary depression of some parts of bone marrow, and significant acceleration of ESR, if normally ESR deviates from 2 to 10 or 15 in women. In leukemia, it's increased to 50, 60, 70 millimeters per hour. But for differential diagnosis between acute and chronic leukemia, first of all, we'll pay attention on white blood cells. And we see that in peripheral blood, leukemic formule will be formed from blast cells, which count may be nearly 99%. And if we reveal only younger form without intermediate forms, which indicates about process of maturation, we are talking about acute leukemia, which characterized with hiatus leukemia, absent intermediate form. Between blood cells and some maturated cells, no any intermediate form. If we see intermediate forms and blood cells not obligatory or maybe but not such significant, we are talking about chronic leukemia. I'll stop on characteristics some variants of chronic leukemia, and first of all on myeloproliferative chronic leukemia. Myeloleukemia is characterized with latent development and significant early splenomegaly. Erythemia or Vaquer's disease is characterized with, first of all, pronounced proliferation of erythroid precursor. As a result, blood of the patient becomes very, very viscous due to increased count of red blood cells. And main complaints of the patient: feeling of burning sensation in the tips of the finger, which is called erythromelalgia. Patient feels skin itching, which increase after bath or shower, which is a specific characteristic because this procedure intensifies blood flow. It's impossible because blood viscous and its speed significantly decrease. And affection of internal organs due to specific thrombosis. It's not true thrombosis due to increased coagulative blood properties and formation of thrombus. It is specific thrombosis due to stagnation of erythrocytes. But patient enters in hospital with clinic any thrombosis. Thrombosis of coronary artery, myocardial infarction. Thrombosis of peripheral artery, gangrene of lower extremity. Peptic ulcer. Acute abdomen due to thrombosis mesenterial vein. Infarction of the spleen and kidney, brain stroke, impaired vision and hearing function due to thrombosis of peripheral vessels. But I'll again pay your attention. It is a problem due to increased blood viscosity, but not due to changing coagulative blood properties. On inspection, we see reddish, first of all, exposed skin, face, neck and hand. Tongue and lips have specific bluish red color due to stagnation erythrocytes in capillary network. Eye conjunctiva hyperemic. All these problems appear due to overfilling peripheral vessels with blood and slow blood flow. On palpation, percussion and auscultation will reveal hepato and splenomegaly, painful tapping of flat bone due to increased hemopiesis and bone marrow hyperplasia, increased blood pressure, which primarily may be assessed as arterial hypertension. And only blood analysis helps you to clear disease. You can compare pathological blood viscosity due to increased count of red blood cells, hemoglobin, reticulocytes, which show intensification of red bone marrow precursor, increased level of thrombocytes, moderate increased white blood cells, and as a result, slow ESR because very viscous blood. And again, I'll pay your attention problem due to increased blood viscosity with normal coagulative blood properties, and usual anticoagulative methods cannot be effective. We can help the patient only due to dilution of blood. Next leukemia on which I want to stop is chronic lymphoid leukemia, lymphoproliferative leukemia, which appears due to hematological problem in B lymphocytes and characterized with specific symptoms. Predilection to high fever, accompanied with severe sweating, especially during night, and early enlargement of lymph nodes. Easy if the peripheral lymph node primary involved in pathological process and patient early go to the doctor. More badly if in a lymph nodes enlarged, which are visible, and patient enters in different departments with different pain into the chest, abdomen, and any other inner organs. On palpation, will pay attention on specific characteristic of lymph nodes. I want that you remember, because in lympholeukemia, lymph nodes whenever fuse one each other, whenever ulcerative and painless. Blood analysis reveal leukocytosis with lymphocytosis, which 80-95% in peripheral blood, and small amount juvenile cells because it is chronic leukemia, and secondary anemia and thrombocytopenia and increased ESR. From lymphosarcoma, I want to stop on example of lymphogranulomatosis or Hodgkin disease, which is systemic disease in the group of malignant lymphoma and characterized with specific malignant affection of lymph nodes, spleen, and other hematopoietic organs, but source of problem in lymph nodes. Clinical picture resembles chronic lympholeukemia, also characterized with early enlargement lymph node, accompanied with high fever and sweating, but it has specific bone defect. Patient feel pain or discomfort in the chest and lumbar region. Then process spreads on the ribs, breastbone, and pelvic bone. Specific order involvement of the bones in pathological process, and specific skin defect characterized with formation nodules with extensive infiltrate. On inspection, we see that patient predilected to sweating. We see scratches on the skin due to severe skin itching, and we can reveal specific skin defect, sometimes along the intercostal space. We'll reveal enlarged lymph nodes, and skin over the lymph nodes becomes red, sometimes bronze color due to disturbed circulation. On palpation, we'll pay attention that lymph nodes form and fuse together with formation conglomerates, which explain why skin of the lymph node becomes dark color because disturbed blood circulation. But they not fuse with skin, not suppurate, and painless as for any blood diseases. Spleen enlarged and form, liver enlargement is less characteristic. More often, patients with blood diseases first of all predilected to splenomegaly and then moderate secondary hepatomegaly. Blood analysis reveal hypochromic anemia and leukocytosis, but lymphocyte count are low, on contrary from lympholeukemia, because pathological lymphocyte will be found into the lymph node, Histological examination of lymph nodes is obligatory, and when we reveal polynuclear cells, which named by author Berezovsky-Sternberg cells, we are talking about lymphogranulomatosis. You see lymphocytes with 2-3 nucleus, polynuclear lymphocytes. And last question on which I want to stop today: hemorrhagic diathesis disease, which characterized with tendency to hemorrhage. Depending on causes, they may be divided on 3 groups: due to increased frigidity of blood vessels, due to disorderly activity of platelets, or due to problem with coagulative factors. I want stop on clinical picture of this hemorrhage. If the bleeding appears due to increased vascular flaccidity, which appears in diseases which you see on this slide, patient predilected to petechial or purpuric hemorrhagic spots on the skin, on mucus, which appears after any pressure, and pressure on the skin on mucus not correlated with activity of hemorrhage. For diagnosis, we'll use specific vessel test which show its increased flagidity and explain predilection of the patient to hemorrhage. Problem with platelets we'll see on examples of thrombocytopenic purpura or Virchow disease, which appears due to immunological mediated destruction of platelets, which may be acute, usually after viral infections, due to formation pathological antigen-antibody complexes which absorb on platelets and provoke their early destruction, or chronic, which develops due to some immune disorders with formation pathological autoantibodies. Clinical picture characterized with different hemorrhage on the skin and bleeding from inner organs, first of all from gastrointestinal tract, kidney and uterus in a woman, without any provoked factor, spontaneous bleeding. More grave if it appears into the central nervous system. I'll pay your attention. On contrary from other cause of hemorrhage, thrombocytopenia is characterized with spontaneous bleeding without provoked factors. On inspection, we can see multiple hemorrhagic spots on the skin and mucus, which appears without any provoked factors. Patient sleeps, gets up with broth. Blood analysis is main method. Examination will reveal decreased level of thrombocytes and as a result post-hemorrhagic hyperchromic anemia. And diathesis due to abnormalities classic factors divided on 2 groups, acquired and hereditary. Acquired is characterized with multiple clotting abnormalities. Hereditary affect only single clotting factors, and will stop on clinical manifestation on example of hemophilia. If we are talking about acquired affection of clotting factors, you see each is multiplied, appears due to deficiency of vitamin K, due to pathology of the liver which take part in hematopoiesis, as a result of disseminated coagulative vascular properties. But I won't stop on Clinical manifestation of hereditary deficiency of clotting factors, hemophilia, which characterized with disordered process of blood coagulation and first of all disordered formation of thromboplastin, which stop initial stage of blood coagulation. As result, blood bleeding cannot stop in type patient characterized with predilection to prolonged blood clotting time. Sometimes bleeding cannot be stopped without specific medication. Clinical picture. Manifested with bleeding into the skin or from inner organs, but only after trauma or surgery operation. And it's manifested early and first of all with hemarthrosis, because when the small children start to walk, it's obligatory accompanied with falling. Which is normally it's not complicated with any problem, but patient with hemophilia immediately appears hemarthrosis or a bruise on the skin due to abnormal activity clotting factors. If the hemarthrosis repeated and prolonged, it's complicated with ankylosis and patient loses ability to independent movement due to rigidity of joints. You see different origin of bleeding which cannot be stopped without specific aid. And hemarthrosis. That's all which I want to talk you today. Thank you for your attention. Be healthy. Goodbye.